Welcome, everyone. I am Rachel Hughes, Community Manager here at Alloy Women's Health. We are a digital health platform bringing science-backed, evidence-based menopause hormonal solutions direct to your door. I am pleased, as I always am, to welcome back to our platform Alloy Medical Advisor and Prescribing Physician, Dr. Corinne Menn. I want to invite you to enter your questions for Dr. Menn into the Q&A, and also let you know that this webinar will be shared on our YouTube channel at the conclusion of this live. And finally, that you may enjoy $20 off over on myalloy.com using the code MHT20. You might have seen it on the banner just before we started. Welcome so much, Dr. Menn, to our last talk of the year. I'm thrilled to share this with you. In thinking about our time today, I couldn't help but think about how menopause conversations have become sort of clouded and confused, especially when it comes to hormones like estrogen and progesterone. But today I wanted to cut through the noise, demystify the basics, explore how hormones impact your wellness and longevity, help listeners understand how Alloy is redefining menopause care. And I'm hoping that this conversation will be sort of like an end of the year roadmap to clarity, confidence, and thriving into next year and throughout midlife. So if I could ask you to start us off, if there is one major misconception women have about menopause that you would want to clear up today, what would that be?
I think that, yes, it's a natural process that if you are lucky enough to get to the age, you will live through, right? And it is not a pathological disease process, but it is a normal part of aging. And in our society, we treat every other aspect of aging and we try to mitigate, the impacts on quality of life, lifespan as well, right? So for instance, you're wearing glasses. We treat our vision declines. We've got a medical industrial complex basically set up to care for all of the chronic diseases associated, with aging, whether it's cardiac issues, brain issues, bone fractures, knee replacements. I mean, the list goes on. But there's a big misconception that just because menopause is natural, that we should just grin and bear some of the effects of it, right? Which is simply not true, because we don't do that for any other thing that has to do with aging. And frankly, we don't do it with much things that are, associated with other aspects of women's health. Like, we don't tell women who are having a baby that, having a baby is a natural process, but we do things to make it easier and safer and improve outcomes. We don't just say it's natural, so go have a baby, in the bush. It's okay to intervene and just have options. And if you choose a more natural approach, that's great. But you should be informed of what benefits you might get from safe menopausal hormone therapy that has been, FDA approved for decades, and we've got decades of data on its safety. So I think that's like this big misconception just about menopause in general, right? That we have to kind of grin and bear it. That's not true. And also just not recognizing that menopause is not just the cessation of being able to get pregnant and the stopping of your periods. It's actually a critical marker in your health of where chronic disease risks accelerate. Okay, across the board, and that menopause impacts every cell of your body. And it doesn't mean that everybody has to use hormone therapy, but that you should be educated about what changes are happening physiologically and what modern science interventions can we do to help you. And that really shouldn't be controversial.
What a fantastic, encouraging, thoughtful answer. Thank you for that. Beyond hot flashes, what are some lesser known benefits of menopause hormonal therapy that can truly, to all of what you've really laid out, sort of improve the quality of a woman's life over the course of the second half of her life?
Well, I think what's really important is to recognize what are the FDA-approved indications, because everybody thinks about menopausal hormone therapy in terms of hot flashes and night sweats. That's what we call vasomotor symptoms. But there's 4 indications. That's one of them. But the reduction in osteoporosis risk and fragility fractures, that is an FDA-approved indication for hormone therapy. And I think that really speaks volumes that most women don't even consider hormone therapy for just that alone. There's many women who say, well, my hot flashes aren't really bothering me. Is this something I should even consider? I'm like, well, just from the FDA-approved indications alone, yes, that's a big one. And then the other one is the genitourinary syndrome of the menopause, which note that it's not just vaginal dryness. That's not what it's called, because it's a true syndrome that's affecting urinary health, sexual health, vaginal and vulvar health, right? So those are just from those FDA indications alone. And then if we step a little bit more forward and really go in a little bit more in depth, and if we just rely on the Menopause Society position statement alone, right, and just read beyond just the bullet points, they do an organ system approach where they review the data on the benefits of hormone therapy on every organ system. And we can go into all the different specifics, but we really do see across the board a great deal of what I like to call secondary benefits of hormone therapy. So it's not the primary indications that FDA has approved hormone therapy for, but those aren't the only things that it helps for. So just because it doesn't have that FDA-approved label, we know a lot about how hormone therapy can, positively impact things. For instance, and we'll talk about what the timing hypothesis means, meaning that ideal window of opportunity to initiate hormone therapy.
Mm-hmm.
Yeah, but alluding to that, that's like basically women who initiate it within the first 10 years of entering menopause. For instance, we know they have a 40% reduction in all-cause mortality. They have a decreased risk of developing type 2 diabetes, right? We know there's profound benefits on the musculoskeletal syndrome of menopause, which, Dr. Vonda Wright's incredible paper, kind of raised awareness on, right? So those are just a few examples, and we can get into others, And so I think when we lose sight of things beyond, we're not addressing things beyond just those, FDA-approved labels. We're kind of, we're missing the bigger picture there. So yeah.
So terrific. Thank you so much for that, for really illuminating the secondary stuff is not less than, right? Yeah. It's just sort of not what the neon light may be shining on, but how it impacts a woman in her day-to-day, in her real life is real and significant. I so appreciate that answer. Thank you. You started to talk about sort of the timing, the sweet spot for hormone therapy. Let us know more about that.
Sure, and always important, because this is really an area where women get confused. Doctors get confused too. So the window of opportunity, or the timing hypothesis, comes from data from the Women's Health Initiative as well as other studies that basically, illustrated that, when women are entering menopause, in terms of, let's talk about really cardiovascular impacts, because that really, women need to understand the cardiovascular system, is intricately linked to brain health, dementia, cognition, right? These two, heart health is brain health, right? So with that in mind, this timing hypothesis tells us that, the menopause transition is a critical time of cardiovascular disease risk acceleration, clearly demonstrated in the medical literature. We know that when women enter menopause, their rates of cardiovascular disease start to climb, right? They're actually double their premenopausal counterparts at any age. So if you're a 40-year-old who's menopausal versus someone who is still getting their periods, your risk of cardiovascular disease is more than doubled. And we see that all the different age cohorts. So we know there's a time where cardiovascular disease risk is accelerating. So if we give estrogen therapy in this time period, ideally first 5 years, but certainly first 10 years, we see not only it's extremely safe in terms of not further increasing cardiovascular disease risk, but a great deal of data suggests that it actually likely mitigates or lowers that risk, right? Not only in terms of cardiovascular disease risk, but also dementia.
Yeah.
Now, you can imagine if you're more than 10 years and you haven't had any, estrogen on board, right? So women who are more than 10 years from their last period or over the age of 60, whichever comes last, not first, right? Because you could have your periods up until say 57 or 56, right? And so your 10-year window starts later. So, your 10-year window would go to about like say 66, right? So when you're after that 10-year window, you have to think about that cardiovascular disease progression has already taken place. We can't prevent what's already happened, right? We can't help mitigate what's already taken place. And that's why, from a safety standpoint and kind of the most bang for your buck standpoint, you're going to get much more benefits in terms of these chronic disease mitigation and perhaps prevention if we started early. Now, of note, hormone therapy is not FDA approved for the prevention of dementia. It is not FDA approved for the prevention of cardiovascular disease. But we can walk and chew gum at the same time, as I like to say, meaning we can recognize that and understand, and there's lots of reasons why it's not been FDA approved for that, but that's a larger discussion. But at the same time, I always have it by my side, the Menopause Society position statement. But at the same time, we can be deep thinkers and we can look at, well, what does the data say about cardiac health and brain health? And what it says is that when we start things earlier, we're getting a lot of benefits. And then we can talk about separately, well, what does it mean for someone who did not start it then, who is outside of that window and they feel they've been left out of the party?
Fantastic. Thank you so much. I'm going to look to our questions coming in because several are coming in and I want to respond to people for a few moments and then we'll sort of jump back and forth. This first question, if I have a history of high blood pressure with birth control, what would you recommend for future treatment of menopause symptoms?
Great question. You have to understand we can't equate all hormonal therapies the same. So birth control pills are made up of a much higher potency synthetic ethinyl estradiol in a much higher dose than what we would be using in menopausal hormone therapy. And they also use synthetic progestins, both of which have been known to raise blood pressure, particularly in women who already have high blood pressure. In addition, women who have high blood pressure their risk of blood clots or stroke is already higher than the baseline. So we tend not to want to do anything that would exacerbate that. So that's where confusion comes in when it comes to when these women go through menopause. And so what's really critical to understand is that we are not concerned about any negative impacts on blood pressure when we use menopause hormone therapy doses, even oral estrogen. So in someone who has high blood pressure where it's well controlled and she doesn't have other big risk factors for cardiovascular disease, for instance, she's not overweight, there's not other, she doesn't have type 2 diabetes, other things, she actually can safely take oral estradiol, menopausal hormone therapy doses, and it does not further increase her blood pressure. But transdermal estrogen is the safer choice for her and has actually been shown to be either neutral or perhaps beneficial on her blood pressure. And the same holds true with, instead of using synthetic progestins, progesterone has also been shown to be either beneficial or at least neutral on blood pressure. And the same thing holds true with cholesterol, lipids like LDL and HDL. These questions often go hand in hand. Well, what about if I have high cholesterol? Once again, menopausal hormone therapy is either beneficial or neutral. And really interesting, oral estradiol has been shown to improve LDL, raise HDL. Transdermal estradiol can improve LDL, does not cause any impacts in triglycerides, and has tons of other metabolic benefits. So bottom line, if you are well-managed, hypertensive, or you have high cholesterol, you can use hormone therapy, and it's important to individualize what we're giving you, but it's certainly not a contraindication.
And the spray, the Evimus spray, we can think of like the transdermal.
Yes, yes.
Okay.
Yeah, I think we're so used to saying like the patch when we're talking about
Right.
transdermal. So when we use transdermal would refer to the estrogen gel, the Evamist spray, or the estradiol patch, right? So those are all ways that we give systemic levels of estrogen via the skin versus giving an oral estradiol pill. But it is important to note that while in general, for many situations, we tend to prefer a transdermal route, oral estradiol is incredibly safe and very beneficial and often a bit more cost effective. So it's an option you can talk about with your doctor.
Dr. Menn, just quickly, could you home in for us clarifying? I listen to you all the time. I'm in this conversation. I feel safe about my choices. I feel safe about encouraging most women to try MHT at the very least. Who are the hard no's? Who is contraindicated?
Yeah, absolutely. So I think in life, actually, there are no absolutes in life, right? So I'm going to give you the contraindications that are, we all accept and, practice clinically with, but understanding that all patients must have an individualized approach to even these contraindications. Okay. So nothing's absolute, right? But the big ones is undiagnosed abnormal bleeding. So if you're postmenopausal and you're having abnormal bleeding, it must be worked up before we give you hormones, right? If you are undergoing active treatment for breast cancer, particularly estrogen receptor positive breast cancer, often those treatments involve things that block estrogen receptors or lower estrogen. So we don't generally recommend hormone therapy in that situation. Once you're done with treatment, that's a totally separate discussion and webinar. But in general, hormone positive receptor breast cancer or other hormone, associated cancers. A history of a heart attack or a very serious cardiovascular disease, and I'm not talking about hypertension of cholesterol.
Right.
A history of a pulmonary embolus or a DVT, a blood clot, although that has a real asterisk by it because depending on whether it was provoked, meaning we know what caused it, like you were in a car accident or you were you were immobilized after like a lengthy, complicated surgery. So if we had a reason of why that blood clot happened, sometimes those patients, again, the caveats could use hormone therapy using a transdermal estrogen that we know doesn't blood clots, right? So those are like the big ones that we think about. But this is why working with like a true menopause specialist and expert is really, really important because for all of those scenarios, we've got ways that we can, look through the data and, explain to patients, well, in your particular case, what are your options? And it's always so black and white.
I appreciate that. Thank you. How do we manage breast tenderness while on HRT?
Yeah, so breast tenderness is a really common side effect, particularly in the first 3 months of starting hormone therapy. It's also a very common side effect when women start birth control pills, right? So it's introducing, a new medication, new hormone, and you can at first have some breast tenderness. If it's mild and it's not bothering you very much, stick with it. It tends to go away, after about 3 months. If it's really, really causing you problems and you're really uncomfortable, you don't have to sit and suffer for 3 months. You'd want to speak to your menopause specialist because it's often associated with the dose of the estrogen. And we often find that just by cutting down the estrogen dose, that can really improve things. Sometimes women get some breast tenderness from the progesterone or the progestogen component of the hormone therapy. So sometimes we can change that around. But I often find just, backing down in the estrogen dose. And I always tell patients, our goal is to meet your symptoms, your menopausal symptoms, by minimizing side effects. We don't want you to suffer with side effects. And sometimes it takes a little bit of, this is the art and science of menopause management. We've sometimes got to play around with doses and formulations to find the best one for you.
Great, thank you.
Rachel, breast tenderness does not mean it's causing breast cancer. A lot of women think, well, if it's tender, does that mean something bad is happening? no, not when we're starting it initially. And sometimes it can happen if we adjust doses. You've been great, and then a year later you're having some more hot flashes. We went up your dose, and so sometimes it can, come then. You should always speak up about any breast changes, but I don't think you should be fearful if you have initial breast tenderness.
Terrific. Thank you. Next question. I wasn't absorbing the patch, so my gynecologist prescribed oral, forgive me if I'm not saying it right, Bijuva, saying it doesn't have risks of other orals. I'm concerned about not following the transdermal message.
Well, listen, Bijuva is a really interesting option, and her doctor was correct in telling her that. So, what's interesting about Bijuva is it is an oral estrogen, and it's combined with oral progesterone in one pill. And there's something about the formulation, and I can't explain it exactly here, but I have to look back at the pharmacology of it. But they have it formulated in a certain oil-based capsule that allows it to bypass that first pass metabolism in the liver. So what we see with Bijuva, which is a brand name product only, there's not a generic available for it, is that there is no increase in clotting factors when we take it orally, right? So that's number one. And number two, remember, even women who take oral estradiol with oral progesterone, which is basically what Bijuva is, they just put it together in a pill and made it into this little kind of fancy combination that is bypassing that metabolism. Even just plain old generic oral estradiol is incredibly safe for the vast majority of women. And the only people who I would not recommend oral estradiol to are women who are at a significantly increased risk of blood clots, an older woman, a woman who is very obese, who has other cardiovascular risk factors. But outside of that, most women can really effectively be managed with oral estrogen.
Terrific. Thank you. Since starting HRT, I've gained at least 20 pounds. I'm currently on 0.375 patch of estradiol only. I had a hysterectomy in 2015. Should I expect to gain more weight the longer I take estradiol?
So the studies have looked at, does hormone therapy increase weight gain? It doesn't, all right? It doesn't, but I will never minimize the patient's experience of that. And a lot of times when women tell me that I started this and now I feel like I've gained weight, a lot of that might be bloating and water retention, number one. The other very interesting thing I see is that, and I don't, of course, know this patient's, full clinical story and how old she was, but if women still have their ovaries, right, and maybe she's younger, I don't know, I'm just guessing this, but women in perimenopause often, right, we know the average weight gain in the menopause transition is 1.5 pounds per year. That's, and so you could see how that can really pile up when we know perimenopause can last for years. And if you have other symptoms going on, like you're not sleeping well and you don't feel as good and you're having a lot of symptoms, you may not be doing the nutritional and lifestyle things that you need to do to really kind of keep that weight off. And so sometimes, it's not the hormone therapy we're giving you, it's this kind of continued accumulation, of weight gain. And if women are perimenopausal, we know that's just a time of rapid weight gain. Sometimes these women actually, if she's perimenopausal, she may also need some progesterone, because if her ovaries are still making a little bit of estrogen and are ovulating, I find these women are at risk of having more bloating. And so she should speak to her doctor about her formulation.
Thank you so much, Dr. Menn. I just want to piggyback off of that question actually and ask this list. I'm thinking about sort of lifestyle and hormones and the synergy between the two. So how do hormones sort of work in tandem with nutrition, exercise, stress management to support long-term wellness?
So I think a couple of basic things is it always gets back to the basic physiology of the menopause transition and what women don't know, right? And so this is what they need to know. As we lose our estrogen, so that estrogen deprivation drives a bunch of things that antagonize your weight, okay? Number one is sleep. If you are not sleeping and you have disrupted sleep and insomnia, that alone, regardless of any hormonal issue that's going on in your life, no matter where you are in your life, sleep deprivation alone lowers basal metabolic rate, right? So you need to burn more calories just to kind of maintain weight, right? So sleep disorder. The lack of estrogen tells your body to start storing more fat centrally around your belly, but deep inside, this is called visceral fat. That visceral fat is metabolically active, meaning it produces things that drive inflammation, antagonize insulin from working, and kind of disrupt glucose metabolism. What does that mean? It means that it's easier to put on weight even if you're eating the same and exercising as you always have been. And then the other third big driver is that when we lose our estrogen, we start to lose our lean muscle mass, skeletal muscle. Skeletal muscle is really metabolically active and helps us burn calories. And as we lose our muscle mass, our basal metabolic rate also gets lowered. So you can see we're not changing eating or exercising, and hormonally and metabolically, our body's changing in ways that antagonize things. And this is why it's super important to address symptoms so that you are sleeping, that you're not so bothered by hot flashes, that you don't feel like moving your body and building muscle. And so hormone therapy, of course, improves all those things, right? So I tell women, hormone therapy is not a weight loss drug. You don't give women estrogen and suddenly they lose weight. But I'd say this is that secondary benefit.
Yes, I was just thinking that.
Right? So all right, so you're giving estrogen, so your skeletal muscle, you're going to not lose skeletal muscle or bone mass as much, number one. You're going to sleep better, right? So then, that improves things. We know women who use hormone therapy have a significant reduction of being diagnosed with type 2 diabetes. So we know that from a metabolic standpoint, it's kind of setting you up for success. Now, if you're not using hormone therapy, it's okay, as long as you understand physiologically, this is what's happening. So hormone therapy might help with those things, but if you're not going to use hormone therapy, then you really do have to dig in and change your lifestyle approaches. You've got to eat more protein. You have to emphasize, maintaining your skeletal muscle mass. You've got to use all the tools to really work on your sleep.
Yeah.
And think about nutrient dense foods, not fad diets. And those things in the long haul will really improve weight. But if we just tell women, oh, it's normal part of aging, what happens is we get to the point where we are in our society now where the numbers are crazy. Over 50% of women are either obese or overweight, right? And so I think just by telling women earlier in their lives, like, this is what's coming, this is what's metabolically going to happen, you can be proactive. And yes, hormone therapy may help. And the GLP-1s we can talk about, they can work synergistically with menopausal hormone therapy, and your lifestyle works synergistically. So it's like a cookie recipe, although that's not a good app.
It's a healthy cookie recipe.
We're using all of these ingredients to get to a better place. And if we're missing one or two of those ingredients, we can still get to a better place, but not as optimally.
Terrific. Thank you. Optimal dosing of estrogen patch for combating osteoporosis. When to re-examine DEXA after starting estrogen to assess progress of improving osteopenia.
All right. So unfortunately, we don't know the absolute ideal dose, but when it comes to bone health, we've got a lot of data we can draw on. So women who are premature menopause, so less than 40, or women who have early menopause, less than 45, we know absolutely the ideal dose is higher. So if you're younger, you need higher, because the earlier you go through menopause, the more rapid the bone loss. And so to combat that, we need to mimic physiologic doses. So in those cases, we've got clear evidence it needs to be at least it'd be the highest dose patch, spray, gel, or tablet. For women who are in the average age of menopause, there does seem to be a dose-dependent impact on bone health. So the slightly higher doses are going to give you a little bit more bang for your buck. But again, I would never want someone to only focus on that one dose. We want really just to use the dose that treats your symptoms while minimizing side effects. And then really interesting on the end of the spectrum, so older women who have either been on hormone therapy for a long time or were not given access to it and want to consider it now. Really interesting that data shows that even the very smallest doses can have a really beneficial impact on your bone, and that the further you are from menopause, actually, the less you need to protect your bones, which is great news for women who want to maybe start past that 10-year window and we want to be more cautious and give them lower doses. They're still benefiting even if they're using low doses, which is
yeah, that's fantastic. Thank you. What blood test will help decide the amounts of hormone therapy needed? Hit us, Dr. Menn.
there is not a blood test per se that's going to tell you the amount needed. The reason why we have all of these FDA approved doses and formulations is because they've all shown to be effective for managing all of the FDA approved indications, vasomotor symptoms, GSM, osteoporosis. And do I wish we had long-term randomized controlled studies looking at each one of those formulations and doses and saying which one is the absolute benefit, better? We don't have that data, right? And so this is why we don't go chasing down a certain level, right? And even when we do, it's very, very interesting. And I've seen it in patients who have come to me with levels already drawn and they're on hormone therapy. And for one woman, she may feel great and her estrogen level is not very high. And other women, their estrogen level, is high on their blood test, but they're still having hot flashes. So we can go up. And that's why we really need to be treating women's symptoms and not a lab test. There's very few clinical scenarios where I need a blood test to really manage things.
Thank you. Does tachyphylaxis or diminishing response to dose happen with hormone therapy requiring an increase in the dose over time?
No, we don't really see that. There's no data to suggest that. Although what I will say is initially, some women are having terrible symptoms and their little receptors have been starved of estrogen. And we will see, we'll give them an initial dose and at first they feel great. And then their symptoms come back as things kind of settle out and you kind of get to this, steady state. And at that time, this is why around 3 months, we always check in with patients and say, how are you feeling? Because some women have an initial good, response. And then they're like, okay, I'm having some breakthrough symptoms. And then generally we can just tweak the dose, either up or down based on their, symptoms and concerns. But generally speaking, once women find the right dose for them, they tend to stay on it for a long of time. There's not this idea that over time, you're going to have to keep on going up and up and up like we do with, there's certain medications out there that could happen with, but not with hormone therapy. And in fact, women over time, as they get older, and this happens a lot when women are approaching 65 and they're like, listen, I want to stay on this for a long time. There's always this discussion of sure, we could try to lower your dose. Again, we don't have any great data that we have to lower that dose, but if it's something you want to do, we can always experiment as we get a little bit older and lower the dose down, because really, again, meeting symptoms, minimizing side effects.
Thank you. Great, great, great. I have an upper respiratory infection. I went to urgent care. The doctor was going to prescribe prednisone, but said she wouldn't because I was on estrogen. I am on 2 milligrams of estradiol. Oh, I see your finger went up. And 200 milligrams of progesterone through Alloy. What is the reason for this? The doctor could not tell me. She just said it's not recommended.
It's because she has no idea what she's talking about. I'm just going to be blunt. That is absurd. If she has an infection and she needs medical treatment for that, her hormone therapy is not a contraindication. I honestly am shocked. I've actually not heard a doctor say that to someone, although I've heard them say lots of other crazy things, because, I think it's really much more important for her to go back to her doctor who is prescribing the hormone therapy, ask them that question. They can review the history, but there is no negative impact between prednisone and menopausal hormone therapy. And to withhold someone's treatment for an infection just because they're on hormone therapy is wrong. And it's because doctors aren't trained in menopause,
Period. End of story. Yeah. Thank you.
Your doctor. Yeah.
Hello. Thank you. I'm 1 year post lumpectomy for stage 1 invasive ductal carcinoma. On tamoxifen since September, 10 milligrams. Can I take HRT now? I'm 48, otherwise healthy. My symptoms are memory loss, brain fog, mood swings. Supposed to take tamoxifen for 4 years. I have vaginal estradiol from Alloy, which is really helping. Thank you.
So right now, the standard of care for early stage breast cancer is between 5 and 10 years of an adjuvant endocrine therapy, right? So, just based on what she's saying here, hers sounds like it was earlier stage, perhaps lower grade, and maybe they were recommending about 5 years of tamoxifen, and she's on 10 milligrams, which is a half dose. Full dose is 20. So she's already tried to lower that dose. We don't have any good data showing safety or efficacy of tamoxifen with hormone therapy. But here's the little asterisk.
Yeah.
Here's the asterisk. In women who are premenopausal, okay, so these are women who have breast cancer, who are premenopausal, who are low risk for disease recurrence. So in a low risk premenopausal woman, what we do for her is we offer her tamoxifen alone without ovarian suppression, meaning she gets tamoxifen, she's still premenopausal, her ovaries are still making estrogen. Because remember, tamoxifen doesn't put you into menopause. It just blocks some of the receptors, particularly in breast or any breast cells that may have escaped the breast area. And this is why tamoxifen lowers risks of recurrence and lowers risk of mortality for breast cancer. But in premenopausal women, they're allowed to have their estrogen along with their tamoxifen if they're low risk for recurrence. So with that in mind, I would say go back to your oncologist and say, hey, in my case, what do you think about this? Number one. Number two, I often tell patients in her situation to discuss with her oncologist what is her absolute benefit from continued adjuvant endocrine therapy. And that benefit will change depending on your individual type of breast cancer and your individual markers there. And you might have a shared decision-making discussion, about whether continued tamoxifen is worth the side effects, number one. Number two, if you continue on it, know that there are non-hormonal things that we can do. And there's a whole toolkit. So I've got a lot more information on that. If they follow me and at Alloy, we can give them a big resource list of a lot of non-hormonal ways that they can try to mitigate some of those side effects.
Terrific. Thank you, Dr. Menn. I'd love to talk about this more also sort of in a future webinar.
Yes, we need that.
That would be great. As a cancer survivor, not breast cancer, and in early menopause at 45 with a family history of breast cancer, weighing the risks versus benefits with hormone therapy. If breast cancer is not a risk, what other risks should one consider when making the decision to take hormone therapy?
Oh, there's a lot in that question. So a couple of more general things. So, there are many cancer survivors out there that have cancer that has nothing to do with an estrogen receptor, and there is literally no contraindication to hormone therapy. And many of those women are forgotten about. There's a lot of cancer survivors that, kind of that menopause is just a second thought, and they don't really get care for that. So, and there's clear position statements. Anybody can Google recently the Lancet Menopause and Cancer. If you just type that in, a very actually nice paper, reviewing that in most cases, women who have a variety of cancers can take hormone therapy, number one. Number two, she says she has a family history of breast cancer that's significant. So right there, and she's already had cancer. So I would want a person like her to know that she deserves full risk assessment with genetic testing, right? So we want to make sure that she knows her actual breast cancer risk, and that's separate from hormone therapy discussion, right? And what ways might she mitigate that risk, right? So she should be referred for genetic testing. And then the third part of that question is, I use this example of BRCA1 and 2 carriers. So these are women who have inherited a mutation that raises their risk of breast cancer. And many of these women have their ovaries removed early to lower their risk of ovarian cancer, which comes along with the BRCA diagnosis. In 2016, the Menopause Society did a really great review and has a position statement. And subsequently, there's been other data published. And what we know on these very high-risk women, right? We know they have up to an 80% lifetime risk of getting breast cancer. And giving them hormone therapy does not further increase their risk. So I like to use that as an example. And actually, in the Menopause Society position statement, which I always have by my side, their language is pretty clear that the preponderance of data suggests that hormone therapy doesn't further increase your risk over baseline. So if your risk is here, it's not making it even higher, okay? And then the last thing is that, she asked, what other risks should I take into consideration when I'm deciding on using hormone therapy or not? So I would say to her, of course, we want to know risks of breast cancer, risks of cardiovascular disease. Are you in that ideal window of opportunity, that 10-year window? But for the vast majority of women who are basically newer to menopause with symptoms, the benefits far outweigh the risks. And I also pose a philosophical question to her or those listening. What is your risk of doing nothing? What is your risk of not treating your symptoms? What is your risks of, white knuckling it through hot flashes, insomnia? What is your risk of osteoporosis? I'd like her to find that out too. And I think, was it in this question or in another one about bone density scans and when you should, was that part of it? Or was that, I wasn't sure whether that was earlier. But so what we know is, when we start hormone therapy or really any intervention for bone health, even the non-hormonal bisphosphonates, in women who have osteopenia, we would repeat it in 2 years. So it takes time to see improvements, right? We're not going to be constantly doing DEXAs. If someone has osteoporosis and is at high risk of fracture, they need to be followed by an osteoporosis expert, and they might be doing their DEXA scans yearly. But for most women who are just tracking over time, the changes either from normal bone density or from osteopenia, the interval's 2 years.
Thank you so much, Dr. Menn. That's fantastic. A couple more questions, and then I'm going to get back to, I want to sort of home in a bit more on progesterone specifically and estrogen specifically. This person asks, can you please explain which hormone has the greatest impact on anxiety? I asked my doctor about progesterone, but she said that I don't need it because I don't have a uterus due to hysterectomy. Is it that simple? The anxiety is new and horrible. I started estradiol patch about 6 months ago.
Yeah, so while it is true technically that women who don't have a uterus do not need progesterone, absolutely, right? So if you have a uterus, you need progesterone to protect the lining of your uterus. And if you give unopposed estrogen, raises the risk of uterine cancer. You don't have any of that risk if you give them with progesterone, okay? Number one. But the question about anxiety, I think it's really important also, and we don't know where she is in her, how old she is, right? So, but what we do know is that both of these hormones are really important for kind of dealing with perimenopausal and menopause-induced mood changes and anxiety. And they work hand in hand. And particularly for women who are perimenopausal, regardless of whether you have a uterus or not, we are ignoring the physiology of what is happening in perimenopause if we ignore progesterone. So what's happening in perimenopause is that you're not always ovulating every month, so you don't have progesterone being secreted. So most women in perimenopause who present with new onset of insomnia and anxiety, it's very, very common. They may still be even getting their periods. Giving them back some progesterone can be incredibly helpful because they're having estrogen. They're still getting estrogen being produced from their ovaries but if you don't ovulate, you don't get the second half of it. You don't get the progesterone, right? So in those cases, I mean, progesterone can just be really, really helpful for anxiety, number one. For women who are menopausal and have really low levels of estrogen, well, then estrogen is going to be really, really helpful there. And those women who have had a uterus removed maybe are less likely to need the progesterone there. But progesterone is incredibly safe. And if you are someone using hormone therapy, you don't have a uterus, estrogen's helped, but your anxiety is still really bad, I would strongly talk to your doctor, a menopause specialist who knows what they're doing, about incorporating safe bioidentical FDA-approved progesterone. Because what progesterone does is it works on receptors in the brain, GABA receptors and other receptors that deal with neurotransmitters, and is, in a kind of a plain speak, is a relaxing hormone in the brain. It helps induce sleep onset, and in general can really be helpful. So I think it's an overlooked option when women don't have a uterus.
So as you're speaking, and I'm thinking about this term, the sort of overlooking the physiology of menopause, which is fantastic, and I'm going to start saying that all the time. You're laying out the benefits, in particular progesterone, but I also hear from a lot of women who say it doesn't agree with me, progesterone, and that I think sort of is a dilemma in and of itself. So to those women, how can you work with them to sort of find the right balance or keep it out if possible altogether?
There's so many ways. So progesterone intolerance is a real thing, and it's probably about 10%. It's, we don't have good numbers that track this, but I'm guessing at least 10% of women will find that they're intolerant to oral micronized progesterone. Does it mean they're intolerant to progesterone? Probably not. No, because their whole lives they've had progesterone, right? Their whole reproductive lives, right? But oral micronized progesterone is a generic medication. The drug companies have literally no incentive to improve upon the formulation and give other options for it. The thing about oral micronized progesterone, and just progesterone in general, is it's very, very poorly absorbed, right? So when we give oral micronized progesterone, it's in an oil-based capsule, and it is it's taken, and it immediately releases the progesterone very, very quickly. So this is why when women take progesterone, we tell them to take it at night because it makes them feel really sleepy, which for many women, they love that. But for some women, that is a lot of progesterone at once, and it makes them feel too sleepy, too dizzy, too woozy. What I wish is that the drug companies would make a sustained release version of it so that it's slowly released over time, right? Because that would get rid of some of those symptoms, right? So that's part of what's going on. The other part of what's going on with progesterone is I said it's a relaxing hormone. In a lot of places, it relaxes smooth muscle tissue. So your GI tract, your esophagus, your bowels are smooth muscle. So some women on progesterone feel bloated, or they have new onset of or worsening of reflux. And there's not a lot of ways around. Progesterone's going to do that if we take it orally in a subset of patients, right? Ways to minimize it: you could take it with some food, you could take it a little bit earlier at night. We can use oral micronized progesterone off-label vaginally, right? This is something you have to talk to your doctor about, but that same exact capsule, it's oil-based. So it actually, when we insert it vaginally, you just can push up with your finger, at night, 100 milligrams or 200 milligrams, it will break down and get absorbed enough to protect the lining of the uterus and give that endometrial protection. Again, it's off-label, but we've got years of clinical experience and other and data suggesting that it's quite protective of the uterine lining. And then you avoid the GI and the oral stuff. And then if that doesn't work, or you don't want to do that, we have very safe synthetic progestin alternatives. Norethindrone acetate, even medroxyprogesterone acetate, which is probably our least favorite because of a variety of some side effects they can have. But those are still very, very safe, and women should not be afraid to use those if they don't tolerate, oral micronized progesterone. And then lastly, particularly for our perimenopausal women, a progestin-containing IUD is a really great option for them, because that's going to protect their uterine lining, and you won't have to worry about those symptoms.
Dr. Menn, are there any situations where progesterone would be taken as a standalone, so no estrogen?
Once in a while, I have patients, actually more than once in a while. So I'd say the scenarios where we find it quite useful would be those in earlier perimenopause. Particularly, they're still getting a pretty regular menstrual cycle, or maybe an irregular menstrual cycle, but they're not suffering from a ton of hot flashes and night sweats. But what they're complaining about is new onset of anxiety, new onset of insomnia. And then they're also saying, but I'm also feel bloated and breast tenderness. I'm skipping my periods, or I feel I feel that, every month, like mid-cycle and the second half of the cycle, for those women, we often will start with just cycling, just some oral micronized progesterone. So that's one, use scenario. And once in a while, we'll have patients who are menopausal and they, for a variety of reasons, may not be a good candidate for oral estrogen or transdermal estrogen systemically. And once in a while, we'll use just progesterone alone. And there are some studies that suggest that even progesterone alone will decrease the rates of hot flashes, night sweats, and insomnia and ease anxiety. So, it is a tool that we can use.
Interesting. Thank you. Question was asked. She says, I'm 2.5 weeks in starting HRT. I got my period and have been bleeding for 5 days straight. What is the fastest way to stop this bleeding? Should I put the progesterone capsule in my vagina? Is it true? And she has a second question, which I'll ask in a moment, but let's start with that.
Well, it sounds like if she started bleeding right now, my guess is she's perimenopausal, right? And so this is the thing. I always warn women who are perimenopausal, hormone therapy, there's an art to it, and it may take time and a little bit of trial and error because your ovaries are doing their thing.
Yeah.
Ovulating or they're not ovulating, but they're making, in an irregular way, and they're making kind of wild levels and erratic levels of estrogen and progesterone. And so when we give back menopausal hormone therapy in that scenario, the doses are not high enough to significantly suppress ovulation and to quiet those crazy hormones down, right? So that's why for some perimenopausal women, a low dose birth control pill, especially given as an extended regimen continuously, where we kind of skip the placebo weeks, really cool that chaos down, right? And that can be a really great option. And so her bleeding coming on right now may simply just be perimenopause.
Right.
And, giving back a little bit of estrogen or progesterone, could it cause some menstrual irregularities? It can cause that. And so that's where she needs to kind of go back to her menopause expert and say, okay, what should I do now? But I would not suggest using the progesterone vaginally that it will magically stop the bleeding. It won't. If anything, backing off on the estrogen is probably going to be more impactful, but it's probably being driven much more by the erratic nature of her own ovarian hormone.
Right. Before I get back to the Q&A, she also asks, is it true, you spoke to this a little, but is it true that I should take progesterone with food? Because I always have a 5-hour fasting window from when I eat dinner and when I go to sleep and take my progesterone. I take 1 tablespoon of olive oil before bed. Could this be equivalent to eating food? And would that help make progesterone more effective? Am I bleeding because I'm taking progesterone on an empty stomach?
No, I doubt how she's taking the progesterone has much to do with her bleeding. There's some data that suggests taking progesterone with food increases its absorption a bit. But it's not something that I think would significantly impact her bleeding. She should take the progesterone nightly when it works for her and not get too muddled down with what she's taking it with.
Yeah. Okay. Thank you. Can you please talk about estradiol levels that you find benefit versus are high? I have severe pain in my hips and back since menopause with numbers like 30, 42. I'm not sure what she means by that. Maybe you do.
My guess is she means her estradiol level.
Okay. I know you don't chase a number, but what would be a number where you tend to see benefits versus too high?
So listen, too high is when you are using beyond what is our traditional, our kind of our FDA-approved options, and you're having, side effects, right? So listen, we don't generally chase down levels, but I will tell you, based on my experience of doing this for a long time, and sometimes seeing women come in with levels, a lot of women, particularly who have symptoms that are still persistent, like persistent joint pain that they find very, very strongly associated with that menopause transition, they tend to need a little bit more estrogen, and probably levels more like 60, 70, 80, probably a little bit higher. So my guess is, and I see this all the time, women start on these lower dose patches, which is fine. I often start women on a 0.0375 or 0.05 because again, we want to minimize any initial breast tenderness or spotting or bleeding. But if she's tried that and she's otherwise tolerating it and she has persistent joint pain, particularly with the joint pain, and I've spoken to Dr. Vonda Wright about this and other specialists who see a lot of women with joint pain, we really need a little bit higher estrogen levels there. Again, I'm not going to chase down her blood test, but I would say talk to your menopause specialist about trying a higher dose, like a 0.075 patch or 1.25 gel, or a higher level of the, see if you're an appropriate candidate for that. And it's really interesting when women have situations like this and we raise their estrogen dose, even modestly, just modestly, a couple of weeks later, they'll be like, oh my goodness, that's what it was. Oh yeah, I see it all the time. Yeah.
Fascinating. I have been on 3 sprays of Eva Mist and noticed hot flashes returning. So I just recently have been switched to 0.5, is it Doty or Dotty patch? I'm not sure. Are these doses equivalent or could I notice changes due to different modalities?
Both. So, women, some women just absorb one modality better than the other. And really interesting, I love the Eva Mist spray. I prescribe it all the time for my patients. I actually use it myself. I love the flexibility and really it is quite low dose, right? The sprays and the gels were developed after the patches. And so there was this kind of, idea that we should be like focusing on lower doses because everyone was afraid of each other. Right. So gels and these sprays were formulated really specifically to have actually quite low absorption levels. And what's interesting about this spray is it's not triple. When you go 1 spray to 2 sprays to 3 sprays, you're not tripling the absorption.
Okay.
Spray, the serum levels get to about these are on the pharmacological, or pharmacodynamic studies of the spray. 1 spray will get you to a serum estradiol level of less than 20. 2 sprays are going to get you closer in the 30-ish range, right? 30, maybe upper 40s. And 3 sprays is maybe going to get you a little closer to 50 picograms per ml on if we looked at a serum level, right? So it's kind of hard to get really higher doses with the spray. It doesn't mean it's not great. Many, many women are really effectively managed, myself including, with even just 1 or 2 sprays, right? So if she was having hot flashes on 3 sprays, a really obvious next thing would be, if she wants to say transdermal, is go to the 0.05 patch, because we know with that 0.05 patch, we're going to consistently get probably a slightly higher level of estrogen. And if that's not enough, we've got 2 patch doses above that can help her, 0.075 and a 0.1. And remember that where we also apply things can change absorption. So our bodies absorb things differently, arm versus belly versus butt, all these different areas, skin thickness, these can all come into how much you absorb. And this is why kind of sometimes trial and error is really all we can do to find the right dose.
Yeah, I think reminding, as you do so well and so consistently, really about nuanced care. And this is that, it's having this conversation, tweaking, and knowing there are options for you. What are your recommendations on reinsertion of an IUD at the age of 55? I currently have a Kyleena and wondered if I can reinsert it next spring or if it's safer, better to just take oral progesterone for reducing the risk of endometrial hyperplasia.
Listen, if you like the IUD and it's working well for you, particularly if you're still perimenopausal or you have any concerns about contraception, although it sounds like she's getting to the age where she may not need it, but it is a very valid, really safe, and really effective way to manage, endometrial protection. And so if she likes the idea of it and it's worked well for her, it's actually quite easy. When they remove the Kyleena, they can just put in a new one at the same time, either a Kyleena, a Mirena, a Liletta. These are great options. So it really comes down to patient preference. I'd say the older the women get, the less likely they're interested in having an IUD for continued, more just because they don't feel like getting the IUD insertion. But it is really highly effective at protecting your uterine. So if it works for you, great.
Dr. Menn, I just want to call out your time and make sure you're okay to keep going for a bit. Okay, thank you. With a history of breast cancer with my mother and aunt, I'm concerned about taking HRT and anything else to help with menopause. Is it okay to take estradiol? A history of sexual desire is 0 and has been for a couple of years.
Yeah, so the very first thing is, as a breast cancer survivor myself, I want you to know that it's super important for you to know your risk of breast cancer so that you can do the proper screening and any mitigation, right? So number one, if you've got a strong family history, she should get genetic testing, and her insurance should pay for it, and she's a candidate for it, right? Number one. And then once you know that, if you have any genetic risk, then you can then discuss any tools, whether it's surgery or other things, to lower that risk. Okay. But that being said, as I said before, your risk is your risk, and adding hormone therapy does not further increase your risk of breast cancer. So if she's having menopausal symptoms, she should not be afraid to use hormone therapy. The Menopause Society position statement makes this extremely clear. A family history of breast cancer is not a contraindication. And remember, even in the Women's Health Initiative, that gets maligned, but we learned, and I'll critique a lot of it, but we learned a great deal of very important information from it. And I want to remind patients that in that very large gazillion-dollar study of thousands of women, it showed that women who took estrogen alone had a lower risk of breast cancer and a lower risk of dying of breast cancer. And then in women who took estrogen with a synthetic progestin, which we rarely prescribe anymore, had the tiniest, and when I say tiny, I mean tiny, so much that it's actually been argued that it wasn't even statistically significant. But taking it at face value, it was an incredibly small risk of breast cancer incidence, but not mortality. And it was less than an additional 1 case for every 1,000 women taking it. And then when they looked at family history or other risk factors for breast cancer, like previous breast biopsies, dense breasts, that it wasn't further increased in women who took hormone therapy. So those are really important safety concerns she should know. So I want to know her risk so she can get the best screening, surveillance, MRI, genetic testing, and managing that if necessary. But I also don't want her to be afraid, because remember, we have to look at all the benefits that go along with hormone therapy.
Thank you. A question came in. I was recently diagnosed with LCIS, classic, found in the pathology from breast reduction surgery. My current high-risk breast doctor wants to limit my HRT to 2 years or less. I'm trying to determine if she's using old WHI data to come to that determination, or if there's a safe way to process with HRT. I currently get twice annual surveillance, mammogram, then 6 months later, MRI with contrast.
Yeah, so listen, LCIS is not invasive cancer, but it is a marker of a significantly higher risk of eventually at some time in your life getting breast cancer. This woman has a lot of options and a lot of things for her that she needs to think about, right? As I've said before, and going back to that kind of analogy that I had with women who carry the BRCA mutation, her risk is high, whether she's a BRCA carrier, whether she just has LCIS alone. She has an elevated risk. Giving her hormone therapy isn't further increasing that risk, right? That being said, she does need to think seriously about her risk of breast cancer and developing it and what that means for her. And so I'm not afraid to give this woman hormone therapy. The doctor, her breast specialist, is likely leaning into some of the data that was kind of misinterpreted and mismessaged, that we should do shortest duration, lowest doses possible. We've kind of moved away from that language. And remember that, for somebody like her, formulation would likely matter to me, right? Somebody like her, I would avoid synthetic progestins. I would stick to a bioidentical estradiol, FDA-approved, or tell her she should speak to her doctor about Duavee, Duavee. It's a really interesting hormone therapy option. We don't currently have it at Alloy. We're working on it.
Yeah.
But when I have a very high risk breast cancer patient, it's not that I'm afraid that hormone therapy that we would prescribe is going to further increase her risk. But this woman is going to be having years of mammograms, ultrasounds, perhaps breast MRIs, right? And everyone's going to be all on top of her, right? She, is going to, be in the position where she might be having, unfortunately, repeated biopsies and stuff. So if there's anything I can give her from a hormone therapy standpoint, that would lower the rate of her having any increased breast densities, any breast tenderness, anything. Bijuva is going to do that for you. So Bijuva is estrogen with a selective estrogen receptor modulator called bezodoxifene. It's shown to be very safe, just like hormone therapy is for breast cancer, but it's being studied to treat DIS and may be a really nice option. It has been shown to show no increased risks of breast densities on mammogram screening. And it's something her breast specialist, I'm sure, knows about. So if she was my patient, I would say, don't be afraid about hormone therapy. But at some point in time, if you keep your breasts and don't consider prophylactic surgery, then Bijuva would be probably my best option for her.
Thank you. Oh, Dr. Menn, for someone who says, I am on MHT, I am still really, really struggling, what might you offer this person? What can they do? They're trying to reach out to a physician. They're just not feeling well. Something's not hitting the mark. What can they think about?
Well, a couple of things. Remember, not everything is menopause, right? So if you're on hormone therapy, number one, we want to make sure your dose is optimized, that you're absorbed well. If you're on hormone therapy and you're still having hot flashes and night sweats, you need to speak up, because we know we can get you to a dose and a formulation that will treat it. It is very unusual for someone to not be able to get effective treatment for their vasomotor symptoms, and also, the subsequent insomnia that also comes around with it. So that's her main thing she's struggling with. So the classic menopausal symptoms of hot flashes, certainly kind of the joint pain like we spoke about, it's often a dose and a formulation thing, number one. If that has been mitigated or it's improved greatly and she's still struggling in other areas, whether it's mood, mental health, sleep, anxiety, I don't know what else is bothering her, right? One, she wants to make sure she speaks up to her doctor to make sure that her, a good overview of the rest of her health, right? Because there are lots of other medical conditions and other things that can make you feel really bad. And also remember that hormone therapy alone is not a magic bullet if we're not leaning into the really important pillars of wellness, which is excellent nutrition, sleep, exercise, community and relationships, and stress reduction. And so it's not a magic bullet, right? And so that's probably the best advice I could.
Your answer to that?
Knowing the limited amount of her medical history.
Yeah. A few more, Dr. Menn. Thank you. Can you talk about surgical menopause for a moment? And I don't know if this is a question or a statement, but she says, will we be okay, with lots of exclamation points? I'm thinking maybe she meant question marks, but I'm not.
Well, listen, surgical menopause is its own unique menopause. It's these women are often neglected. Now, listen, the reason why you had surgical menopause may impact what your options are. Will you be okay? Yes. If you're talking about menopause, yes. So surgical menopause is different because it's abrupt. It happens overnight, right? You remove the ovaries, you remove dramatically estrogen, progesterone, and 50% of the source of your testosterone, right? If it happens early, so before the age of 45, and certainly before the age of 40, well, that is really significant, because you go from functioning hormonally to having basically zero hormones overnight. Not okay. And those women, unless there's some real true contraindication, they should frankly be waking up with that prescription or that estrogen patch already on, frankly. Yeah. So that's number one. If you were already menopausal or around the age of, I should say, if you were around the age of natural menopause, a lot of doctors just minimize you then having surgical menopause. So for instance, you're 49 or you're 50 and your periods are already irregular. Maybe you have a little bit of hot flashes already. They're like, no big deal. We're just going to remove those ovaries and your uterus now, and it's not a big deal. You're already almost menopausal. Who cares? Yeah. Well, actually, a post-menopausal ovary that's still present, is making testosterone, and it is actually making very low levels of estrogen. So surgical menopause, even in the, that natural age of menopause woman, is still different, right? And 1 in 8 women in the US, Rachel, this is crazy. 1 in 8 women will lose their ovaries prior to the age of natural menopause for benign reasons, meaning non-cancer reasons, right? And less than 50% of those women are offered hormone therapy, which is the standard of care, because the long-term morbidity and mortality of untreated premature surgical menopause is huge, upwards of 70, 80, 90% increased risks of dementia, osteoporosis, cardiac disease, you name it, right? So if you're early, you must have full HRT. If for some reason you can't, which I wonder about this patient's questions, will we be okay? If you're surgical menopause and you absolutely, for whatever reason, cannot take systemic estrogen therapy, you can still be okay. You are not destined to a life of cardiac disease, fractures, and dementia. But you better demand from your doctors that they are going to talk to you about all the other ways to help mitigate either symptoms or chronic disease risk. And that's the problem, is those patients are often forgotten about. Will you be okay? Yes. Will you need to advocate for yourself and really get educated and be super proactive? Hell yes.
Thank you, Dr. Menn. I'm now 71, menopause at age 50. Can I safely start topical hormones at this point to get benefits of them?
So when she says topical, there's a great example of how we have to understand there's local topical, that would be vaginal estrogen products. And then there's topicals like transdermal patches, sprays, or gels that are systemic. In general, someone who is more than 20 years from their last period over the age of 70, we are very cautious at reintroducing estrogen at this very late stage. Does it mean we absolutely can't do it? No, but we're very, very cautious, because remember, we're always balancing benefits versus risks.
Yeah.
So, are there some, less common scenarios where we might reintroduce systemic hormone therapy then? Maybe if someone had just horrific, persistent, vasomotor symptoms that have just been unrelenting for all those years, because there are a subset of women where they'll have those symptoms forever. And then weighing benefits versus risks, right? But if she means topical, at any age, you can start topical vaginal estrogen, which is not systemic and can be really beneficial for a woman of any age. So if you're a 70 or 80-year-old woman who has genitourinary syndrome of menopause symptoms, regardless of whether you're sexually active or not, you can greatly benefit from vaginal estrogen, which is topical, right? But I would be much more cautious about systemic topical therapy. Not that it's totally out of the question. And there's been a recent paper on this. And I was on a podcast with Dr. Haley Casperson where we asked, what is the risk? And actually the risks are lower than you would think, right? But it's a much more careful nuance. And if you think you're going to suddenly have lower dementia or lower cardiac disease if you start hormone therapy after the age of 70, the answer is no. That ship sailed.
Yeah. About vaginal estrogen, someone asks, can vaginal atrophy or GSM be reversed? I'm 10 plus years in menopause, have been unable to have sex. Even getting a gynecological exam is painful. I've lost sexual desire and my marriage is sadly impacted. I've started using her estradiol cream a few weeks ago, and I'm starting to notice less pain and dryness.
Good news is it can be reversed. And I'm sorry you had to suffer this long. You never should have. It is a crime. And literally, I could spend my entire time on Instagram, my whole account could only be educating women on vaginal estrogen and the need for it and how safe it is. But you have really good news is that, yes, consistency is key. It can take up to 12 weeks to repair the vaginal microbiome, to really start to improve the pH, start to thicken up the tissue, improve lubrication. And yes, women will notice improvements as quickly as a week or two. But give it time. At 12 weeks, you're going to start to see real benefits. And then beyond that, keep up. The consistency is key. And that is the first part. And we didn't really get to the biopsychosocial model of sexual dysfunction, but this question kind of leads to this, that, right? Biopsychosocial, bio is physical, right? So pain. Here's a great example. This woman has had terrible GSM, so painful, so she doesn't want to have sex because your brain is your biggest sex organ.
Sure.
What do you think your brain is going to do when it sees, okay, this is going to be an act of intimacy, I'm going to have sex? Well, your brain is going to be like, no, girl, that's hurt. It's
Not today.
your body. Not only your desire is going to go down, but your muscles in your pelvis are going to clench up and make sex that much more painful. So this is why I say, yes, we can refer patients to like cognitive behavioral therapy and, couples counseling. But if we are not treating the pain point, we're never going to get there, right? So be hopeful, treat the pain, add in a good lubricant and also a good vaginal moisturizer that can help. And then at that 12 weeks marks, that's when you can start to consider how you can then reintroduce intimacy in ways that is gentle. So you might start with vaginal dilators, vibrators, other forms of non-penetrative sex to start to program the brain that sex can be pleasurable.
Yeah.
But we never want to push it too much. And that I have seen women like her, and it can take time. It can take 3 months, 6 months, a year. And they slowly start to get it back. And suddenly a year later, they're like, wow, my sex life is back. My intimacy is back. I'm not getting urinary tract infections or urinary frequency. So there's so much hope for her.
Thank you, Dr. Menn. 2 more questions, and then I'm gonna allow you to wrap us up. This is this person's question. This might be a ridiculous question, but here it goes. I'm taking a compounded testosterone, estrogen, progesterone cream. I've heard estrogen cream is good for facial skin. Is it bad to rub the cream into my neck? Does it mess with the thyroid at all?
I want her to say, want her to know. Okay. First of all, there's no reason to compound estrogen and progesterone in a cream. Number one, we have FDA-approved estrogen, transdermal options, gels, patches, sprays, right? Okay, progesterone, we will never, ever recommend progesterone cream. It will not protect your uterine lining, okay? It's just not absorbed sufficiently in a transdermal manner. You cannot use progesterone if you cannot use progesterone cream if you're using systemic levels of estrogen. The testosterone compounded, I'll come back to at the end, because that is one hormone that we sometimes have to compound, and that's okay, all right? So number one, the combo of a compounded product is bad. You know why? Because we don't know where symptoms are coming from and we can't individualize. So I don't like having everything combined, number one. Number two, topical estrogen is very, very helpful for skin health. We know it's really helpful for vaginal and vulvar health. And we know topical facial estrogens are incredibly safe, very effective. Our M4 study showed how effective the M4 estriol face cream and aloe is, but understand that face cream is not systemic hormone therapy, okay? So I would not recommend taking a combination estrogen, progesterone, and testosterone, putting it on your face. Is it gonna hurt your face? Probably not, right? But we don't have any data on topical testosterone on facial skin. And in fact, we avoid using topical testosterone gel or compounded testosterone cream for low sexual desire. We tell patients, in fact, put it in an area like the back of your calf or your inner thigh, because it can increase hair growth, okay? We don't want hair growth on your face, right? And we have no good data on what topical testosterone is doing to facial skin. So what I would recommend for her is use FDA-approved transdermal estrogen for systemic estrogen, use an oral progesterone or other option for progestin, and get her testosterone, if she's using it for low desire, get it compounded separately, or women can use FDA-approved 1% testosterone gel that is made for men, but they use it at a much lower dose. So those are the 2 ways we give testosterone for low desire. And we don't recommend testosterone pellets because it makes testosterone levels go really, really high. But what happens is when women are in a menopause care vacuum, they get funneled to doctors who are practicing non-evidence-based medicine and doing red flag things like needless compounding. Compounding has a role for certain medications out there, but not for hormone therapy for the vast majority of women for estrogen and progesterone. And anybody out there who is telling you that progesterone creams protect your uterine lining doesn't know what they're doing and is actually totally practicing non-evidence-based medicine and putting you at risk for getting uterine cancer if they're also giving you systemic estrogen. So that's a huge red flag. So come to Alloy. We'll help you with your hormone therapy. And you can continue to use testosterone, but separately and appropriately dosed.
Dr. Menn, you lead me to essentially at the last question. You're talking about the menopause care vacuum. You're amplifying Alloy as a platform to get real menopause care. What problem is Alloy solving really to this? If you could speak about what we do, what we offer, and sort of what the benefit is to women.
Absolutely. So listen, Alloy is leveraging digital health and helping to democratize access to true menopause experts who are certified, board certified physicians, mostly OBGYNs, who have advanced training in menopause management and are practicing evidence-based medicine. Because we know that there is a lack of clinical education in OBGYN residency programs and primary care residency programs. The vast majority of doctors in primary care or OBGYN are just not well equipped to counsel women on the physiology of menopause and perimenopause and offer them evidence-based treatment options. And even if those doctors are well-versed, which in some surveys, less than 7% of them report that they are, it's very, very hard to get in with them.
Yeah.
There's long wait times, lack of, coverage, and just kind of sometimes geographical barriers. Millions, over 4 million women live in areas of the United States that have a OBGYN care desert or very limited, access. So by digitizing this and offering this digital health platform, it makes it, one, really convenient because we're in all 50 states, right? And we are lucky that we have this very deep bench of hormone therapy experts and doctors who truly are menopause experts. And we really pride ourselves that the doctors practicing here are following the evidence-based guidelines and combining that with their many years of clinical experience. And I think this is something that's really unique because, yes, anybody can read, as you know,
yes,
Menopause Society position statement. People can take a course, they can go to the Menopause Society and do their Menopause 101 thing. But unless you've had literally decades of years in the trenches of meeting face-to-face with women, helping them through their women's health concerns, from breast cancer risk to bleeding issues to fibroids. I mean, I've seen and done it all. I've been in the OR. I've taken care of all these women. So when it comes to menopause, me and my colleagues at Alloy, we know how to manage all of those different women's health concerns when it comes to menopause and hormone therapy. So you can't, you can't really put a price on this really valuable resource that this clinical experience combined with evidence-based medicine that we have here at Alloy. What's great about Alloy is we make it super convenient too, right? And so we all know how busy doctors are and how busy women are with families and careers and other things, right? And so once you come to Alloy, you get assigned to a physician who's licensed in your state. And it's asynchronous. So we review your symptoms and your history, and then we can message you at any time back and forth. So we have this really ongoing line of communication. Because as we learned during this webinar, right, it's not that hormone therapy is really complicated or, really hard to do, but it often takes some trial and error and a lot of visualization. And so by having this open and easy line of communication, we can make changes quickly. We can alleviate concerns or side effects or answer questions really, really quickly and effectively in a manner that I think is really disrupting the space in a really positive way, right? Because the old, model of, waiting months for an appointment, then you get there, you've got 10 minutes with the doctor, and then if you've got problems or you want to change things, you've got to make another appointment and come back in 3 to 6 months later. And that is just really, that kind of is a huge barrier for many women in actually getting evidence-based adequate menopause, care. And so I think for all of those reasons, I think Alloy is really, a special platform and has set itself apart because of the ease of communication, the access to real experts, right? We're all board certified physicians here. And so I'm really proud to work here. And that's why I chose to practice on the Alloy platform.
Thank you. I appreciate all of what you said and didn't mean to put you on the spot. I just really wanted to sort of unpack sort of the void for so many people. A couple of things I wanted to say is there are a lot more questions that we did not get to, but we're pushing 90 minutes and I do want to give Dr. Menn back her day. You have in the past, again, I don't want to put you on the spot, but for people who didn't get their questions answered, we can respond to them offline. So we'll figure out how.
And we can also we can answer some of them on our Alloy stories today and tomorrow. So,
okay, perfect. If that's
some of those questions, why don't we do that? I'll go into Alloy stories and we'll answer some of them.
Thank you. And I guess finally, again, right, we're closing out the year. Alloy had a birthday this year. We're 3 years old. Thinking ahead to sort of all of the silos of wellness, health outcomes, all of the work that you do, all of the work that Alloy does as a team. What would you leave women with? The end of this year, looking to next, there are going to be women here who are sort of on the fence for one reason or another about hormonal care or any number of things. Sort of what would you say goodbye to your patients as they're walking out of your office with piece of advice?
I would say take a deep breath. Don't worry about all the noise out there. You know your body better than any doctor out there. If you are in this menopause transition, you're having symptoms, you have concerns about things like osteoporosis, sexual health, other chronic diseases, arm yourself with education. Come to Alloy, the YouTube channel that we have now, all the webinars you've done with physicians, other doctors on Alloy, as well as other leading experts. I'd say this end of the year, give yourself a little time to pause, right? That's what menopause is good about. Like it's making you kind of pause and think a little bit more deeply about yourself. Educate yourself, because when you're empowered and educated, as Dr. Sharon Malone always says, give women good information, they'll make really good decisions for themselves. And I promise you, this is really not that complicated.
Yeah.
And you really deserve to feel great and have not just a long lifespan, but a really high quality health span. So you've got this.
Oh, thank you for that, Dr. Menn. What a beautiful way to close this out. Thank you all who came today. You're getting lots of thank yous and you're awesome. And we're so lucky to have you here at Alloy. Thank you to all of you who came. Happy end of the year. Happy New Year when it gets here. And any questions, please do reach out to me or Dr. Menn, anyone on the Alloy team. We will help you navigate to your best self. All right.
Amazing. Thank you for having me, Rachel.
A pleasure always. Thank you. Bye, everyone.